Hey, before we dive into the tough stuff, let's make sure everyone's clear on the four main numbers we always get on a lipid panel: total cholesterol, LDL, HDL, and triglycerides. These are the backbone for every question and decision about hyperlipidemia.
Exactly. And every time I see those lab results, I always check LDL first since it's the bad cholesterol, right? The mnemonic L for lousy totally sticks with me.
You nailed it. Elevated LDL is the villain behind heart attacks and strokes. For boards, remember, below 100 is very good, but anything above 200 is red alert high.
And then there's HDL, the healthy one. More is better here. I always remind myself, higher HDL means less risk, but weirdly, raising HDL with meds doesn't prove to help much, right?
That's the classic exam trick. Elevated HDL is a good sign, but targeting it doesn't change outcomes like lowering LDL does. Oh, and before we move on, don't forget about triglycerides. If they shoot over 800 or 1000, think pancreatitis risk, not just heart disease.
Oh wow. So those sky-high triglycerides are more about saving the pancreas than the heart. Makes sense. That actually brings me to the next question. How do we define hyperlipidemia overall?
So hyperlipidemia just means elevated cholesterol, LDL, or triglycerides, though it's the LDL number that really drives up cardiovascular risk. This is why practically every adult gets screened at some point.
And it's not just genetics, right? I keep hearing about lifestyle like too much saturated fat, sitting around, and not enough fiber. These all push the numbers up.
Definitely. It's one of those problems we can actually do something about. Improving diet, getting moving, and quitting smoking all make a real dent. The cool part is, since it's modifiable, even small changes matter for long-term risk.
Honestly, I find that motivating. Like, these aren't just numbers on a page. There's stuff we can change before someone ends up with a heart attack or stroke. Speaking of causes though, aren't there some sneaky things that boost lipids besides lifestyle?
Great segue. Most hyperlipidemia cases are primary, meaning there's no underlying disease, just genetics and lifestyle. But secondary causes are real exam favorites.
I always trip up on those. Like, what are the big secondary culprits I should remember if I see a sudden spike in cholesterol?
Think alcohol, pregnancy, and some meds, beta blockers, and thiazides especially. Plus, diseases like hypothyroidism and nephrotic syndrome love to mess with the lipid panel.
So, if a patient's numbers suddenly go wild, I should check for those before calling it just bad genes or fast food. That totally changes management. Speaking of management, what's always the first step once we actually diagnose hyperlipidemia?
You're on a roll. Step one is always lifestyle diet tweaks, exercise, weight loss, quit smoking. But once risk is high or targets aren't met, we turn to medications. And statins are the gold standard.
So, who absolutely needs a statin versus just lifestyle? I get confused between moderate and high intensity and all those risk calculators.
Classic question. If someone has known vascular disease like prior heart attack, stroke, or peripheral arterial disease, they go straight to a high-intensity statin. Diabetes over age 40, moderate or high intensity. LDL over 190, that's high-intensity territory too.
And then there's the ASCVD risk calculator if their 10-year risk is over 7.5% statin time, right?
Exactly. The calculator uses age, gender, cholesterol numbers, blood pressure, diabetes, and smoking to spit out your risk. It's in every major guideline now. But achieving targets matters too. Let's talk about what those are. So, our LDL target for most is under 100. But if someone already has vascular disease, shoot for under 70. It's all about layering risk reduction.
But here's what always trips me up. Hyperlipidemia is usually silent, right? Patients don't walk in complaining about high cholesterol.
That's the sneaky part. It's the classic silent killer. But with extreme levels, we sometimes spot physical clues. Xanthomas, those yellow skin bumps, tendinous xanthomas, or a corneal arcus in the eye.
Now that you mention it, I remember seeing a photo of a tendon xanthoma in a test question. It was a dead giveaway for familial hypercholesterolemia. And speaking of those, can we break down the different familial dyslipidemias?
These are board favorites. Type 1 is hyperchylomicronemia, think crazy high triglycerides, milky plasma, pancreatitis risk, and it's autosomal recessive. Type 2 is familial hypercholesterolemia, super high LDL, early heart attacks, and those tendon xanthomas we just mentioned.
And if I see a young person like in their 20s with an MI and tendon xanthomas, that's basically type 2. What about type 3 and 4?
Type 3 is dysbeta-lipoproteinemia, both cholesterol and triglycerides high, often with xanthomas and premature heart disease due to an ApoE problem. Type 4 is all about increased VLDL linked to diabetes, hypertension, and low HDL.
So if the numbers point to sky-high triglycerides, I think type 1 or 4. If it's LDL, that's type 2. And type 3 is both together with elevated risk. Got it. While we're talking about treatment, how do statins actually work again?
Statins block HMG-CoA, reductase the rate-limiting enzyme in cholesterol synthesis. That leads to more LDL receptors on the liver and drops LDL the most, but also bumps up HDL and lowers triglycerides a bit.
But then come the side effects. The muscle aches are legendary. I always remember the spectrum. Myalgias are just pain, myositis has a high CK, and rhabdo means super high CK, dark urine, and kidney trouble.
Exactly. And don't forget about the liver statins can cause hepatotoxicity. Plus, drug interactions are a classic test topic. Macrolides, azoles, HIV meds, cyclosporine, and even grapefruit juice can all boost statin toxicity.
That grapefruit thing trips up so many people. But let's not forget, statins aren't the only drugs out there for lipids. What about the others?
Absolutely. Niacin raises HDL and lowers LDL, but flushing is its signature side effect. Take aspirin first to help. Fibrates like gemfibrozil are for high triglycerides, but watch for myopathy and gallstones.
Ezetimibe is another one, blocks cholesterol absorption in the gut, right? Not super powerful, but can nudge down LDL. Then there are bile acid resins, good for LDL, but they can cause bloating and even vitamin deficiencies.
And don't forget about fish oil, omega-3s lower triglycerides, but leave you with a fishy aftertaste. The latest buzz is PCSK9 inhibitors, alirocumab and evolocumab. These are injectables, drop LDL dramatically, but they're expensive and mostly for tough cases.
It's wild how many options we have, but the core exam questions always circle back to statins, risk, and those familial patterns. Maybe we should cap things off with a quickfire review?
Let's do it. If you remember nothing else, LDL is the bad guy, HDL is the good guy, and triglycerides mean pancreatitis if they're sky high. Statins first for almost everyone at risk.
And the must-treat patients. Anyone with ASCVD, diabetes over 40, LDL above 190, or a 10-year ASCVD risk above 7.5%. For familial stuff, type 1 is triglycerides, type 2 is LDL, type 3 is both, and type 4 is VLDL.
That covers the absolute highest yield points. If you can rattle those off, you're ready for test day and the wards.
Honestly, this was the most efficient hyperlipidemia review I could have hoped for. I feel way more confident now.
Glad to hear it. Hyperlipidemia is everywhere in medicine. If you get these basics, you'll handle both board questions and real-life patients with confidence.
Thanks for listening, everyone. Next time you see a lipid panel, you'll know exactly what matters and what to do about it.
Last time we dove into hyperlipidemia, but today, let's tackle hypertension. This one's just as crucial, maybe even more so, because it's everywhere in board exams in real life.
I still remember in med school how often hypertension would come up paired with high cholesterol. They're like the troublemaking duo of cardiovascular risk, double the damage when they show up together. Stroke, heart failure, kidney disease, you name it, their fingerprints are all over it.
That's why getting the diagnosis right is everything. And here's the key. You can't just go off one high blood pressure reading. Lots of folks get a bump from nerves or rushing around. So guidelines say you need more than one measurement before calling it hypertension.
Totally. I've seen patients freak out after one high reading at a checkup. But unless you've seen that elevated number at least twice, on different days, you hold off on the label. It saves a lot of unnecessary worry and meds.
Ever get those numbers jumbled? Here's a breakdown that sticks. Normal is under 120 over 80. Once you hit 120, 129 on the top, but stay under 80 on the bottom, that's pre-hypertension. Cross the 130 systolic or 80 diastolic line, and you're in stage 1.
And if you're at 140 systolic or 90 diastolic, that's full-blown stage 2. But what always tripped me up early on was the crisis range. systolic over 180 or diastolic over 120. That's flashing red lights territory for sure.
That number seems to be everywhere in board questions. Hypertensive crisis is a favorite, but not every case of high numbers means an emergency, right? There's nuance to that, depending on symptoms and organ involvement.
Exactly. Which actually leads nicely into the types of hypertension because not all causes or consequences are created equal.
Most people have what we call primary or essential hypertension, which basically means we don't know the root cause. It just happens. And genetics can play a big role.
I was amazed how often kidney problems sneak in as the real culprit for secondary hypertension, though. Chronic kidney disease tops that list, but don't forget exam classics. Things like hyperaldosteronism, renal artery stenosis, or even pheochromocytoma pop up all the time.
And then there's white coat hypertension, so common. You get these anxious readings in clinic, but at home, the numbers are perfectly fine.
What makes it tricky is knowing when to trust the readings. Sometimes you'll need home or ambulatory monitoring just to sort out whether it's the real deal or just nerves.
Let's tease apart risk factors, because you really can't tackle hypertension without knowing what fuels it. Family, history, and race, especially African American background, are things you can't change, but they matter a ton.
For sure. But what I see most in practice is the modifiable stuff. Diet, salt, alcohol, weight, lack of activity. I always tell patients shaving off a little salt or a few pounds can drop your blood pressure by more than any starter med sometimes.
And the boards love to sneak in alcohol if someone drinks regularly and their blood pressure's up. The correct answer is almost always to cut out the booze. The numbers often fall pretty quickly after that.
Funny you mentioned that because obesity and inactivity seem to be everywhere too. It's like the trifecta: salt, alcohol, and weight. Get those under control and you'll see a huge impact.
Here's what really scares me about hypertension. It quietly damages blood vessels everywhere. Stroke, heart attack, kidney failure, even aortic aneurysms. It's all on the table if blood pressure stays high.
Absolutely. I met a patient once who felt totally fine, but routine labs showed protein in the urine. Turns out their kidneys were already taking a hit. That silent damage adds up fast.
And you might not even know until something big happens, a stroke or heart attack out of nowhere.
That's why early detection is so important. We can't wait for symptoms because half the time there are none until it's too late.
So, you've got a new hypertension diagnosis. What's next? The big move is screening for complications. Think diabetes, high cholesterol, kidney, and heart checks all at once.
That's where the familiar tests come in. Hemoglobin A1C or fasting glucose for diabetes, lipid panels, an EKG to peek at heart changes, creatinine for kidney function, and urinalysis to spot protein.
It feels like a lot, but it's all about catching damage early. If a board question says new hypertension, screening is your go-to answer.
Exactly. It's almost reflex at this point. New diagnosis, check for silent damage every time.
Let's talk treatment, because this catches people all the time. First step is not a pill, it's lifestyle change. Weight loss, cutting salt, moving more. Even a small weight drop can lower blood pressure by a lot.
I always laugh when someone asks for a prescription before giving the DASH diet a try. That diet, lots of veggies, whole grains, lean meats, and low sugar has serious effects, sometimes stronger than a single drug.
If that's not enough, then we add meds. First line include thiazide diuretics, ACE inhibitors or ARBs, and certain calcium channel blockers like amlodipine.
Totally. And don't forget, if the boards mention a patient with a specific medical history, the drug choice can shift. Let's unpack that next.
So here's a classic board twist. If someone's had a prior heart attack, you grab a beta blocker. For diabetes or any signs of kidney disease, ACE inhibitors or ARBs are your go-to because they protect the kidneys.
And if osteoporosis is in the picture, thiazide diuretics get a gold star. They nudge calcium levels up a bit, which helps bones. Protein in the urine? Again, ACE or ARB to the rescue for renal protection.
It's basically like matching the med to the patient's risk profile. Quick recall on exams, but even more important in clinic.
I've had so many patients who fit into multiple categories. Sometimes you get to tick off 2 boxes with the right medication.
Now, what about those times when things really go south? Hypertensive urgency means sky-high numbers, but no organ damage. Still scary, but not an emergency yet.
But the real crisis is when those high numbers come with signs of organ damage like confusion, chest pain, vision changes, even kidney issues. It's not just the numbers, it's the context.
And if you spot papilledema on exam, you're in malignant hypertension territory, a true emergency subset.
What a lot of folks miss is you can't drop the pressure too fast. That actually puts organs at risk too, especially the brain.
So, in the hospital, these emergencies call for IV meds, hydralazine, labetalol, nitroprusside, and a few others. But the big point, lower the pressure gradually, around a 25-30% drop in the first couple hours, not all at once.
Nitroprusside is memorable because of its unique mechanism. It releases nitric oxide, which relaxes both arteries and veins, dropping the pressure fast. But hang on to this. If you use it too long, cyanide toxicity becomes a risk.
Cyanide toxicity is sneaky. It messes with the electron transport chain and can cause lactic acidosis. That's why it's for short-term use, only ideally, less than 24 hours.
That actually reminds me of ambulatory blood pressure monitoring. It's how we catch those tricky cases of white coat or masked hypertension by tracking real-life numbers over 24 hours.
Ambulatory monitoring is such a game changer. Cuff goes off every 15 minutes and gives a true picture, especially for people whose clinic readings don't match their home numbers.
It's perfect for nailing down white coat hypertension, or the opposite masked hypertension, where everything looks fine at the doctor's but spikes outside.
All right, let's hit the highlights before we wrap. You need 2 measurements to diagnose. Most cases are primary, and kidney disease is the top secondary cause.
For new hypertension, always start with lifestyle changes. First-line meds are thiazides, ACE, ARB, and calcium channel blockers. And don't forget to screen for diabetes, lipids, kidney, and heart issues every time. Last thing, hypertensive emergencies bring organ damage, and nitroprusside can cause cyanide toxicity if used too long.
You know, last time we unraveled hypertension, how it quietly damages blood vessels. But today's story is about what happens when that same process reaches blood vessels outside the heart and brain. Peripheral vascular disease.
The fascinating part is how everything links up. There's this cardiovascular domino effect. High cholesterol, high blood pressure, atherosclerosis, and suddenly you're dealing with blockages in places like the carotid or leg arteries. This isn't just trivia, either. On exams, understanding this chain is pure gold.
For sure. And the first stop on that chain, carotid artery disease, which is sneaky but can have huge consequences. Let's dig into that.
You got it. The carotid arteries are like expressways to the brain, so any traffic jam there can spell real trouble. Let's see how that actually happens.
Most people with carotid artery disease have no warning signs at all. It's often just a random carotid brute on exam or something picked up by chance on imaging. Kind of wild, isn't it?
Honestly, it's a little unsettling. The danger comes when a plaque forms at the carotid bifurcation, then ulcerates or throws a clot to the brain. That's when you get things like TIAs or even a full-blown stroke.
And when someone's had a thanks in advance or stroke within the last 6 months, we actually call it symptomatic carotid disease. That changes everything about how aggressively we treat it.
It sure does. And it's not just any stroke symptoms, think classic MCA territory issues. Vision problems, weakness, numbness, maybe even trouble speaking, if it's the left side. But there's also that classic board question, amaurosis fugax.
Yes, the temporary curtain coming down over one eye. That's a mini embolism to the eye. Okay, so if someone's asymptomatic, is there any clue they might have carotid disease?
Sometimes you'll catch a carotid brute. Otherwise, it stays hidden until we go looking with tests. Speaking of which, let's walk through how we actually diagnose it.
For diagnosis, carotid duplex ultrasound is the real workhorse non-invasive and gets the job done. If things look serious or we're planning a procedure, we'll reach for MR or CT angiography.
And sometimes, especially right before an intervention, invasive angiography comes into play. Once we've nailed down the diagnosis, the treatment conversation really kicks in. There are 2 procedures: open surgery to clear the plaque carotid endarterectomy, or a stent to keep the artery open.
And here's a high yield point. All patients, surgery or not, get statins, aspirin, blood pressure, control the foundational stuff. But whether we intervene surgically depends on just how blocked things are and if they've had symptoms.
Exactly. For asymptomatic folks, we only jump in at 80% blockage. Symptomatic? The threshold drops to 70%, except for men with 50, 69% stenosis. They sometimes get a green light for intervention too. Otherwise, medical therapy rules the day.
Before we shift to the limbs, there's one quirky vascular condition that pops up on exams: subclavian steal syndrome.
Oh, that one's a favorite. Let's dive into what makes it so unique.
Subclavian steal's all about blood taking a detour, reversing flow in the vertebral artery because of a blockage in the subclavian. On exam, you'll see a big blood pressure difference between the arms, especially after exercise.
It's almost like a plumbing reroute. People might get arm pain, numbness, or rarely dizziness with activity. Diagnosis usually involves ultrasound, and if needed, you can fix it with bypass or a stent. But moving down the body, peripheral artery disease, PAD, is where most questions really focus.
PAD happens when arteries in the legs narrow, most commonly in the aortoiliac or femoral arteries. The classic symptom is claudication, pain with walking that's relieved by rest. It's all about the muscles not getting enough blood during activity.
That's right. Plus, the location of the pain can help localize where the blockage is. Pain in the buttock points to aortoiliac disease, while calf pain suggests femoral or popliteal. There are also classic physical exam findings: hairless legs, shiny skin, even ulcers.
And don't forget, Berger sign elevating the leg causes it to go pale, and dangling it brings a flush of redness. It's such a classic, high-yield finding. Speaking of which, the Rutherford classification helps us stage how bad the PAD is.
Absolutely, and those stages range from no symptoms all the way to tissue loss. But the real diagnostic star is the ankle brachial index. Let's break that down next.
So, the ankle brachial index ABI is simply the ankle blood pressure over the arm blood pressure. A normal result is around 1, but if it drops to 0.9 or below, that means there's PAD. Super easy to do and highly sensitive.
It's such a simple test, but so revealing. And you can even do an exercise ABI if you suspect early disease. Imaging like ultrasound, CT, or MRI can help map out the vessels if you're planning an intervention.
While we're at it, let's spotlight the biggest risk factor: smoking. That's the one that shows up over and over in every exam vignette. Other risks, diabetes, hypertension, high cholesterol matter too, but smoking tops the list.
I always tell students, if you can remember just one thing, make it that. Now, as for treatment, people often think limb loss is the biggest worry with PAD, but it's actually stroke and heart attack that we fear most. So, everyone gets antiplatelet therapy, statins, and aggressive risk factor control.
And for claudication itself, exercise is first line. It actually helps the body build new pathways for blood flow. There's a drug called cilostazol, but the evidence is only modest. If someone has severe limb-threatening ischemia, that's when we bring in the big guns: stenting or surgery.
You know, speaking of emergencies, acute limb ischemia totally changes the game. That's where fast recognition matters most. Ready to tackle that?
Acute limb ischemia comes on suddenly, usually due to a clot or embolus blocking blood flow. The classic causes: atrial fibrillation, tossing off clots, or sudden thrombosis on top of a nasty plaque.
And the 6 P's are the key signs: pain, pallor, pulselessness, poikilothermia, paresthesia, and paralysis. If you see mottled skin livido reticularis, that's a really bad sign. Time is muscle, or rather, time is limb here.
Diagnosis is usually with a CT angiogram, which shows exactly where the blockage is. Treatment always starts with IV fluids, keeping the leg down, and a big heparin dose to stop more clot from forming.
Then we have to move fast: thrombolysis, surgery, or sometimes, sadly, amputation if the tissue is already dead. It's one of those true emergencies where recognizing the signs can literally save a limb.
And before we wrap, there are a couple more vascular oddities like aneurysms and atheroemboli that are exam favorites. Want to quickly hit those before we summarize?
Definitely, let's give those their spotlight, then pull everything together with a rapid review.
Aneurysms are basically ballooned out arteries, usually the popliteal or femoral, and can lead to sudden limb ischemia if they clot off. Pseudoaneurysms are a little different. They don't involve all the vessel layers, often show up after catheterization, and are treated with surgery or a stent.
and atheroemboli, tiny cholesterol pieces that break off, especially after procedures, and cause weird symptoms like skin mottling or even eosinophilia in the blood. Usually we treat those supportively, but they're a must know for exams.
So, to tie it all together, carotid plaques mean stroke risk. ABI below 0.9 signals PAD. And claudication means pain with exercise that goes away with rest. Smoking is the #1 risk factor for PAD. And don't forget, acute limb ischemia is a true emergency with those 6 Ps.
That summary hits all the high points. And remember, for PAD, exercise is the first treatment to reach for, but the biggest threat is actually stroke or MI, not just losing a limb.
We've covered a ton. Next time, we'll round out the cardiovascular story with a deep dive into coronary disease and heart failure. Can't wait for that discussion.
Me neither. This kind of integration is what makes all the puzzle pieces click. Looking forward to it.